All right. So sorry about that. And my topic today is reducing adverse reactions and toxicity through correct administration of IV antibiotics. So the practical approach. So what I am going to discuss today is this effects of antibiotics. And antibiotics are different. So they are not like other drugs. They act on bacterial cells and structures, and they kill bacteria simply. All other drugs will act on host cells and systems. Antibiotics lack useful action on host. All actions on host is either adverse reactions or toxicity. Effects of antibiotics, there are two effects of antibiotics. One is desired effect, so that is what we are expecting from antibiotics, that is bacterial killing. The second one is the undesired effects, so that is the action of antibiotics on host cells, so that is the adverse event and toxicity. Aim of my presentation is to give some inputs on how to prevent adverse events and toxicity associated with IV antibiotics and antibiotic administration. So I will be skipping this part because we have gone beyond the time. So we are talking only about undesired effect of antibiotics and how to avoid them. First, definitions. So adverse reactions, basically Dr. Danushka have given a definition of adverse reaction, and I will start with drug toxicity. Drug toxicity means deleterious or undesired effects of drugs when caused following administration of higher than normal doses. Adverse reactions are harmful reactions which occur when you administer a drug or an antibiotic in approved doses. But toxicity is unlike adverse event. It is due to administration of drugs higher than usual doses. Adverse reactions are unavoidable. So therefore, if you are expecting an adverse effect for a particular drug or an antibiotic, it is always better to avoid it rather than continuing it. Toxicities, in contrast, are avoidable. So therefore, it is always you can avoid toxicity than adverse reaction. So in my presentation, I will be not talking about prescribing errors, which is another common happening in our prescription, and also intentional overdoses. So they do not fall into the category of adverse drug reactions. Classification. So there are several classifications. So I'll be talking about several single classification, which is WHO approved classification in 2005. Hope you can follow this. So there are dose-related adverse reactions, non-dose related adverse reactions, dose and time. Hello, can you hear me? Hello, can you hear me? Right. So dose related. Hello, guys, disturbance. I'm hearing a disturbance. I don't know. Somebody hasn't muted the microphone. Right. So there are time-related reactions, withdrawal reactions, and unexpected treatment failures. So when you consider the antibiotics, so all these antibiotic adverse reaction classes may not seen. So when you are discussing about the antibiotic adverse events, so you will get dose-related reactions. So that is, example is vancomycin red man syndrome. I will be discussing it later. Then the non-dose related adverse reactions, example anaphylaxis, idiosyncrony reaction with chloramphenicol, and sulfur reaction with cotrimazole. So those are non-dose related. It's not dose dependent. Then the dose and time related events, which is antibiotic toxicities associated with poor renal clearance, like vancomycin and aminoglycoside toxicities. Then the time related, so it depends on the time, the infusion and all. So that is vancomycin-Redman syndrome, and there is no withdrawal reaction, antibiotic associated adverse events, but unexpected treatment failures you can get with antibiotic interactions. Other types of reactions which does not fall under categories of adverse reactions or toxicities also common in clinical setting. One example is you get excessive pain when you are being administered with certain antibiotics, for example, cephalosporins and penicillins. So this is something common in Western countries where you give cephalosporins or penicillin through a peripheral line, the patients will scream of pain. So that is not due to adverse event or a toxicity. So that is due to osmotic active sensitive receptors in venous system where it gets stimulated when a high concentration of cephalosporins or penicillins were given through a peripheral line. So therefore, it is very much important to consider giving it to a larger vein when administrating certain antibiotics. So then the next category of reactions which does not fall under adverse drug reaction is the complement mediated reactions. Here the main thing is dissolving antibiotics in distilled water. Sometimes the volume may not be adequate to dissolve the whole, or you can get microaggregates in the solution. So therefore when you infuse it, so you will get a complement mediated reactions, not directly associated with histamine release or any other mechanism. Here basically due to poor dissolving of antibiotics in water for injection. Then other one is the electrolyte and renal function issues associated with certain antibiotics and antifungal when it is administered. For example, amphotericin preparation. So you give amphotericin, few days time you will get a electrolyte problems and some renal function issues. The other other event which is not classified as an adverse event, but you can get with certain antibiotics like amoxicillin and ampicillin. For patients who are having viral fevers, if they given these drugs, they will get a skin reaction. So they are not directly classified as adverse events according to the definition, but may be associated with antibiotics. So the common adverse events. The famous adverse event associated with antibiotics is the Redman syndrome or vancomycin flushing syndrome. Here it is a pruritic erythematous rash on face, trunk and upper torso, mainly in the upper part of the body. Sometimes may be associated with weakness, angioedema or pain in chest or back. So this is due to a non-immune mediated histamine released from mast cells and basophils. So the appearance is something like this. So generally this is due to rate dependent infusion related reactions. So suddenly if the rate of infusion or administration of vancomycin is increased for more than 10 milligrams per minute, you will get this vancomycin associated Redman syndrome. The next group of diseases are anaphylaxis, where I am not going to discuss because it had been extensively discussed. So the third antibiotic associated adverse event is the chloramphenicol induced bone marrow suppression. Here chloramphenicol is known to cause bone marrow suppression. So there will be two reactions, dose dependent and dose independent, and basically this is due to reversible. The dose dependent chloramphenicol induced bone marrow suppression is due to reversible inhibition of mitochondrial protein synthesis and ferrochelates found in the inner membrane of mitochondria. So as I mentioned, there are two bone marrow suppressions. One is dose dependent, the second one is dose independent, and that is a idiosyncratic reaction. The dose independent one will cause bone marrow suppression and aplastic anemia even if it is administered in minute quantities. the sulfur allergy, the third group of antibiotic associated is the sulfur allergy. Sulfur allergy is due to sulfonamide drugs and its derivatives. Could be mediated by many type of allergic reactions, and manifestations may vary from mild to severe form. The term sulfur allergy is a misnomer. Actually, it is not due to elemental sulfur in products. So if the allergic reactions are due to elemental sulfur in products, we might not be able to infuse any of the antibiotics because most of the antibiotics contain elemental sulfur. But actually, this allergic reaction is due to arylamine group in sulfonamides and other closely associated derivatives. So here is the moiety which brings up sulfur allergy. It is called arylamine group. Therefore, rather than using the term sulfur allergy, it's better to use the term sulfonamide allergy for describe this condition. The next one that I'm going to discuss is the vancomycin and aminoglycoside renal toxicity. Here, this occurs due to accumulation of both the drugs. So vancomycin and aminoglycosides can be accumulated if you give it more frequently, and also if you administer the drug in certain patient populations with compromised renal function. Here you can get accumulation of vancomycin and it can lead to end organ damage. Here the renal damage is said to be dose related, right? And it is reversible if detected early. So the treatment option available for us is to detect it early and omission of culminative drug. So here we are at a disadvantage because none of our hospitals have the facility to test for vancomycin and aminoglycosides in our test repertoire. Because of that fact, we are not in a position to predict the possibility of vancomycin and aminoglycoside allergy timely manner. Then the next group of disorders associated with antibiotics are the ototoxicity with aminoglycosides. Ototoxicity is another known adverse event, and it is said to be irreversible. So then there's another group which is available, that is another group of adverse events, which is vancomycin associated ototoxicity. So this is due to a dose dependent accumulation, and it is usually associated with prolonged use of vancomycin. It is said that cumulative dose of 25 grams in a person who has normal renal function will develop vancomycin associated ototoxicity, and it initially manifests as high tone deafness. So the ototoxicity initially occurred due to high tone sounds only, but later it can progress to sounds which is low tone. So if you are suspecting of high tone deafness in a patient after prolonged usage of vancomycin, as in case of treatment for infective endocarditis, you can always refer the patient to ENT surgeon and test for high tone deafness. And when as a policy in Kandy, so we had a policy to test for high tone deafness if we are continuing vancomycin for more than 10 days as we are treating for cases of infective endocarditis. So the other effects of antibiotics are the antibiotic interactions. So there are unknown interactions which happening inside the body and known interactions which can occur in vitro. So here the famous example is interaction between penicillins and gentamicin. So we all know that penicillins and gentamicin is a very good combination to counteract certain organisms. But if you mix the solutions in vitro in a same syringe, you will get interaction. And as a result of this interaction, the potency of both the drugs will go down and you can get unexplained treatment failures associated with this. So how are we going to reduce adverse reactions and toxicity associated with medicine? First, how to prevent red man syndrome. So the red man syndrome, as I have just discussed earlier, it is associated with increased rate of administration, infusion rate of administration of IV vancomycin. So if you reduce the infusion rate to 10 milligram minute speed, you can effectively reduce the possibility of developing red man syndrome. So that is why when we are prescribing vancomycin, we always specify the time period. So that is to give the vancomycin dose over 2 hours. But at the same time, you have to specifically ask the nursing staff never to increase the dose rate to continue the vancomycin within that time period. So what we have noticed in our setting is it is being given as a 2-hour infusion, but in certain instances the rate increases in order to administer within 2 hours of duration. So the key message that I want to convey when we are administrating vancomycin, that rate has to be maintained throughout the infusion and it should not exceed 10 milligrams per minute at any moment. It is not just the whole time duration, but it has to be maintained throughout the infusion time, never to exceed the speed of 10 milligram per minute infusion. In patient developing RMS, if you come across a patient who has red man syndrome, still you can continue antibiotics, vancomycin, by pre-medicating this patient before a vancomycin dose with chlorpheniramine and cimetidine. So we all know cimetidine is not available in Sri Lanka. So therefore, you can pre-medicate the patient before anticipated vancomycin dose, 1 hour before anticipated this thing, with chlorpheniramine and cimetidine, and you can infuse vancomycin for that patient who had developed red man syndrome earlier. So it is worthwhile to note that vancomycin is a drug where you can give to a patient who has allergy, severe allergy to penicillin as well. So if you want to drug which can be given as a substitute for patients who has severe anaphylactic reaction to penicillin group, this can be given. True vancomycin allergies are rare. Most reported vancomycin allergic reactions are usually infusion-related reactions or minor degree red man syndromes. So therefore, you can avoid it by lengthening the infusion time to maybe 3 hours or more than 3 hours, and also trying to pre-medicate with chlorpheniramine and cimetidine when it is necessary. For true vancomycin allergy, you can consider giving alternatives. But if you analyze the patients who gives a history of vancomycin allergy, it is not true vancomycin allergy, but a rate associated, increased rate associated reactions that they have experienced. So how to prevent anaphylaxis? Again, we have discussed it earlier. Prevention of chloramphenicol associated bone marrow suppression. As I mentioned earlier, chloramphenicol, if you give to anybody, can cause bone marrow suppression at one point. So therefore, the best thing would be to avoid chloramphenicol, because in our formulary, there are lots and lots of alternatives for chloramphenicol. So then it's better to avoid chloramphenicol whenever possible, so that you can avoid. Sulfur allergy, again, the same thing. You can screen with the history and also can avoid the responsible drugs. So what sulfur containing drugs are safe to administration? If a person has given a history of sulfur allergy, so these things are, you can see, You can't use sulfur drugs, Bactrim, Septrin, sulfadiazine for patients who have established sulfur allergy or sulfonamide allergy. But these drugs, where the acetazolamide, metazolamide, and these things, although they have sulfur moiety, the sulfonamide moiety, the aryl amine moiety, which is responsible for sulfur allergy, they can be given under observation. And although the sulfites and sulfur and sulfate, although they have sulfur in their formulations, you can safely give these drugs, the ones in the right hand corner, without any problem for patients with sulfur allergy. The prevention of toxicities associated with gentamicin and vancomycin, you have to monitor the drug levels. So actually the monitoring drug levels is a chemical pathologist role. And in Kandy, when I was working in Kandy, we had the machine in nephrology unit, and we used to measure vancomycin and aminoglycoside levels, especially amikacin and gentamicin, from nephrology laboratory when we tend to give vancomycin and gentamicin or amikacin for longer durations. So that services were available earlier, but I was informed that reagents were no longer available due to present crisis in Kandy. But I think vancomycin and aminoglycosides being one of the commonest prescribed intravenous antibiotics in the country, that facility of measuring drug levels has to be there in at least larger institutes. So how are we going to use potentially renal toxics and other endocrine toxic drugs in sepsis? So this is another hot topic, where how are we going to treat the patients who are renally compromised and coming with critical conditions with sepsis. So we all know, even these patient categories have compromised kidney. Any delay or any low dose administration will increase the chances of death from sepsis. So therefore, antibiotic concentrations at the site of infection considered to be the most important factor govern the recovery of these patients. So therefore, if you happen to treat with aminoglycosides or vancomycin, still you can give first 1 or 2 days the normal dose, and later you can tail off the doses in order to suit the renal functions. In critically ill patients, so they shows increased renal clearance. That means whatever the drug that you give, they will be excreted from the body system. It is known as augmented renal clearance, and therefore even in patients with marginal renal function or compromised renal function, because of this altered body fluid compartments and the body physiology, it is always better to give normal doses and fill the body fluid compartments rather than trying to cut down the antibiotics from the presentation. So you can reduce the antibiotic doses later once the patient recovered from sepsis. So this augmented renal clearance will enhance the renal clearance. So therefore, it is worthwhile to keep that in mind when you are treating patients who were renally compromised and coming with sepsis. So as I mentioned earlier, this type of patients may need to give normal or higher doses at least in the initial period of the infection or sepsis till they were recovered from sepsis. So adverse reactions are unavoidable and toxicities are avoidable. So therefore need to identify them and work according to prevent the ill health of both adverse event and toxicities without compromising the lives of patients due to clinical conditions such as sepsis. So thank you very much.